when it's the middle of winter and your house is just absolutely freezing and you finally turn on that old central heating system, you are desperately hoping for instant warmth.
Right, yeah. But the reality is the house doesn't just instantly become a balmy 72 degrees. I mean, the heat is coming. It just has to, work its way through the architecture.
Exactly. And before you feel any of that warmth, you hear the noises, the pipes start to clank, they bang, they groan. You might even get that weird, that dusty smell from the radiators.
Oh, absolutely. The burning dust smell.
Yeah, that one. And you're sitting there shivering on the couch, wondering if you just broke the whole system or if it's actually doing anything at all. Well, welcome to the deep dive. We have a very specific mission today, tailored directly for you, the listener, who might be sitting in that metaphorical freezing house right now, just waiting for relief.
It is a really tough place to be in.
It really is. So we are tracking the exact timeline of when hormone replacement therapy, or HRT, actually starts working. And we've pulled together this massive stack of clinical guidelines for this. We're looking at data from the NHS, the British Menopause Society, 9CE, and detailed treatment timelines from specialized clinics like Voy and Mira Fertility.
It is, frankly, a phenomenal amount of data. And by synthesizing all these sources, what we get is a highly predictable, evidence-based roadmap. It shows us exactly how the human body responds to this treatment over time.
Okay, let's unpack this because I know there is so much frustration out there. When you start a medical treatment, especially for something as disruptive as menopause symptoms, you want to know exactly when the relief is arriving.
Naturally, you want a timeline.
Right. But what all these clinical sources agree on is that HRT is not a light switch. You don't just flip it and the darkness is suddenly gone. It's much more like a dimmer switch.
That's a great way to look at it. You have to remember that the body is undergoing a massive physiological transition. I mean, when estrogen and progesterone levels drop during menopause, it affects almost every major system in your body.
So it's not just one isolated thing.
Not at all. So when you introduce supplemented hormones, instant relief is incredibly rare. But as the data clearly shows us, there is a distinct biological sequence to how and precisely when specific symptoms begin to fade.
Which brings us back to those clanking pipes. The first 14 days of treatment. You take that first pill or you apply that first patch, and you are expecting to feel better, but initially you might just feel strange.
Yeah, the clinical timelines refer to these first 2 weeks as the adjustment phase. Your body is absorbing these supplemented hormones and basically trying to establish entirely new baselines.
And that adjustment can actually be kind of uncomfortable, right?
It can be. During this window, it is incredibly common to experience mild estrogenic effects. So this can manifest as breast tenderness, slight bloating, mild headaches, or even, a bit of nausea.
See, that is where I think the friction happens. If a patient starts a medication to feel better, and in week 1 they're just bloated and nauseous, the immediate instinct is going to be that the treatment is failing.
Right.
Or that their body is actively rejecting the hormones entirely.
And it's a completely understandable reaction, which is why understanding the biological timeline here is so vital. The absence of immediate relief, especially when you combine it with these transient side effects, it does not indicate a failure of the therapy.
It doesn't mean it's not working.
Exactly. Biologically, it simply proves that your body is actively metabolizing the hormones. Your cellular receptors, which have been, frankly, starved of estrogen for a while, are suddenly waking up and reacting to this new influx.
So to use that earlier analogy, the noise isn't a malfunction.
Right. It's the physical evidence that the fuel is actually moving through the system.
Okay, so the initial discomfort is essentially just the sound of the system waking up. Once the system settles down and those receptors adjust to the new baseline, we look at what actually warms up first. And according to the data across all these clinics, the body's temperature control center is the early victory.
Yes, the vasomotor symptoms. So your hot flushes and your night sweats. Those are almost always the very first to respond, typically between weeks 2 and 4.
Just 2 to 4 weeks.
Yeah, and the clinical data is quite striking here. We see up to an 85% reduction in these symptoms overall.
Oh, wow. 85%.
Yes, with a 77% drop in the frequency of hot flushes alone.
I mean, a 77% drop in just a couple of weeks is a staggering change for someone who has been suffering through dozens of flushes every single day.
It's life-changing. And what's fascinating here is the positive feedback loop this creates, particularly regarding sleep, because the hypothalamus is this small region in the brain that acts as your body's thermostat. When estrogen levels fluctuate wildly, the hypothalamus essentially gets confused. It mistakenly thinks your core body temperature is dangerously high, so it triggers a massive drenching sweat to cool you down rapidly.
Which is the hot flush.
Exactly. HRT stabilizes that thermoregulatory function. When you stop the false alarms, you directly prevent those 3 a.m. drenching wake-ups. And that leads to an almost immediate boost in daytime energy and sleep quality, often within just 1 to 3 weeks.
Okay, let's dig into that sleep mechanism for a second.
Yeah.
Because menopause insomnia is a massive issue for so many listeners.
It really is.
Is the supplemented estrogen actually acting as a sleep aid in the brain?
Yeah.
Like a sedative? Or is the patient just finally getting a good night's sleep purely because they aren't waking up soaked in a pool of their own sweat?
It is heavily weighted toward the latter. The immediate dramatic improvement in sleep during weeks 2 to 4 is almost entirely mechanical.
Mechanical meaning you just fix the broken part.
Right. You are removing the physical disruption. You are no longer being startled awake by a biological false alarm that spikes your heart rate and just floods your system with adrenaline.
Because it's hard to sleep when you're full of adrenaline.
Impossible, really. Once you remove that adrenaline spike, you start getting consecutive hours of uninterrupted sleep. And consecutive sleep cycles are what actually allow the body to finally start doing its deeper neurological repair work.
And that mechanical fix to your sleep is exactly what unlocks the next stage of relief. Because once your brain finally gets a break from those middle-of-the-night adrenaline spikes, it suddenly has the physiological bandwidth to deal with the cognitive symptoms.
Exactly. The sources refer to the period between weeks 4 and 8 as the clarity phase. This is when things like mood swings, irritability, and anxiety really begin to stabilize.
And the brain fog.
That follows right behind. The dreaded brain fog and cognitive changes start to lift. The clinical data we're looking at shows an 83% improvement in mood and emotional symptoms, and 73% of patients report significantly clearer thinking.
So what does this all mean? It means if you are listening to this and you are, say, at week 3 of your treatment and you are still forgetting where you put your keys or you find yourself crying at a random television commercial, do not panic.
Please don't.
Neurological and emotional recalibration just takes longer than simple temperature control.
That is a crucial takeaway for anyone tracking their progress. It's a dual benefit at work in the brain. Yes, you have the direct hormonal effects of estrogen on neurotransmitters like serotonin, which help regulate your mood.
Right.
But you also have the indirect, compounding benefits of finally paying off your sleep debt. You cannot underestimate how much of that brain fog is simply the result of accumulated chronic sleep deprivation.
Because you haven't slept properly in months or even years.
Exactly. When you don't hit deep sleep, your brain literally cannot clear out the metabolic waste that accumulates during the day. So once the brain is physically rested and cleared of that waste, the hormones can effectively do their job of stabilizing your emotional baseline.
Okay, so your internal temperature and your mood can recalibrate in a month or two. But repairing actual physical tissue is an entirely different biological process. Which brings us to the slower burning symptoms. These are usually stretching from week 6 to 12, and honestly, often well beyond that.
We're talking primarily here about genitourinary syndrome of menopause, or GSM.
Right.
This encompasses the physical changes: vaginal dryness, pain during intercourse, and urinary frequency or even recurrent UTIs. The clinical guidelines are very clear that this is often the absolute slowest system to respond to systemic HRT.
So how long are we talking?
It takes a minimum of 6 to 12 weeks for most patients to notice significant improvement.
Which, when you think about the mechanics of tissue repair, that timeline makes perfect sense. It's like trying to revive a completely dried out houseplant.
Oh, that's a good comparison.
You cannot just pour a glass of water on the topsoil and expect the leaves to instantly turn vibrant green again. The water has to seep into the soil, the roots have to slowly soak it up, and the actual cellular structure of the plant needs time to physically rebuild itself from the inside out.
That analogy perfectly illustrates the biology here. When estrogen levels drop, the vaginal epithelium, the actual tissue lining, thins out and loses its elasticity, and the local blood flow decreases significantly. The natural flora and pH levels change, which is exactly what opens the door to those recurrent urinary tract infections.
Ah, so it's a cascading effect.
Exactly. To reverse that cascade, estrogen replacement literally needs time to revascularize the tissue. It has to build back those tiny blood vessels, restore the acidic pH that protects against bacteria, and physically thicken the cell layers. It is structural repair. It's not just a chemical signal. And structural repair demands time.
And the guidelines make a really stark distinction here between GSM and the other symptoms we've discussed so far.
If we connect this to the bigger picture, the distinction is critical for your long-term health. Because a hot flush is incredibly disruptive, yes, but for many women, the vasomotor symptoms will eventually pass on their own after a few years as the body adjusts to a naturally lower hormone baseline.
So they sort of age out of the hot flushes.
Yes, but GSM does the exact opposite. Without treatment, GSM usually worsens over time. The tissue atrophy just continues to progress.
Which sounds awful.
It is. Because of this, the guidelines state that indefinite usage of local vaginal estrogen is very often required to maintain that structural integrity. And importantly, local estrogen, like a cream or a localized pessary, it has minimal systemic absorption.
Meaning it doesn't really enter your whole bloodstream.
Exactly. It stays right where you put it, meaning it can be safely used indefinitely, even alongside systemic HRT like a patch or a pill.
Okay, so knowing that structural tissue repair takes months, the immediate question for anyone sitting in that frustrating waiting period is going to be, can I speed this up? Like, does the vehicle you use to deliver the hormones change the timeline? Let's look at the data on patches versus pills versus gels.
The clinical sources do spend a lot of time analyzing delivery methods. We essentially have two main categories. We have transdermal methods, which are your patches, gels, and sprays, and then oral methods, which are your traditional pills.
Right.
Transdermal methods deliver estrogen directly through the skin barrier and straight into the bloodstream. By taking this route, they completely bypass the digestive system and the liver.
And that's the famous first-pass effect we see in pharmacology, right?
Precisely. When you swallow an oral estrogen pill, it goes into your stomach, enters the digestive tract, and it must be metabolized by your liver before it can reach the rest of your systemic circulation.
So the liver gets to it first.
Right. This first pass through the liver filters out a significant portion of the hormone, and it can cause slight fluctuations in hormone levels throughout the day. By entirely bypassing the liver, transdermal patches and gels provide a much more stable, consistent level of hormones directly into the blood.
So it's a smoother delivery.
Yes. Because of this direct route, some patients report symptom relief a few days earlier than they might with oral pills. Furthermore, and this is a major clinical advantage highlighted in the NICE guidelines, transdermal routes carry a significantly lower risk of venous thromboembolism, or blood clots, compared to oral estrogen.
Hold on, let me stop you there. If transdermal patches bypass the liver, if they provide more stable levels, if they work faster, and they have a lower risk of blood clots, taking a pill sounds completely obsolete. Why isn't every single prescription a patch or a gel?
Well, it seems obvious on paper, but that ignores the nuance of long-term medical treatment and individual human biology. While it's true that patches might give you a slightly faster start in those first few weeks, the clinical data definitively shows that by the 3-month mark, the overall outcomes and symptom relief are virtually identical regardless of the delivery method.
Really? They completely level out?
Yes, the timelines completely converge by month 3.
So the delivery method is basically just a short-term race that ultimately ends in a tie.
That's a great way to view it. The choice of how to take your HRT often comes down to highly practical individual factors rather than just clinical superiority. For instance, some women have biological factors that result in poor skin absorption, so a gel simply won't process effectively for them.
Oh, interesting.
Yeah. Others develop severe skin sensitivities or harsh allergic reactions to the specific adhesive used in the patches. There are also very real considerations regarding cost effectiveness and simple daily preference.
Right, because you have to do this every day.
Exactly. Some people find applying a gel and waiting for it to dry tedious, and they much prefer the routine of just taking a pill with their morning coffee. The ultimate goal of any chronic therapy is adherence. The best method is always going to be the one the patient will consistently use without friction.
That makes total sense. You have to live with the treatment every single day, so it has to fit your actual life. And all of this data, the initial adjustment phase, the sleep improvements, the brain fog lifting, the slow tissue repair, and the delivery methods, it all points toward one universally agreed upon checkpoint in the medical guidelines, the 3-month milestone.
Yes, 12 weeks is the clinical gold standard for assessing HRT effectiveness. By this point, according to the aggregated data, roughly 88% of patients feel their hormones are balanced and their symptoms are adequately managed.
88%.
Yes. The initial side effects have completely subsided, the physical tissue repairs are well underway, and the neurological pathways have recalibrated.
Now, that 88% figure is fantastic, but it leaves a very important 12%. What about the listener who reaches month 3? They circle that 12-week date on their calendar. They wake up, and I simply don't feel better.
The sources are incredibly emphatic on this point. Reaching 3 months without full relief is not a failure of the therapy.
It's not.
No. It is simply a data point indicating that a clinical pivot is required. Every woman's absorption rate and receptor sensitivity is completely unique. If you aren't feeling balanced at 12 weeks, it usually means a dose adjustment is needed, or perhaps a change in the delivery method we just discussed.
Okay.
In some cases, if specific symptoms like profound low energy and a complete lack of libido remain stubborn, it might indicate the need to add testosterone to the treatment plan.
Here's where it gets really interesting. One of the sources we reviewed includes insights from Dr. Heather Curry, the former chair of the British Menopause Society. And she points out this massive paradigm shift in how we view these treatments. She notes that the goal of HRT is not just to get you on the lowest possible dose to merely survive your day.
Exactly.
The clinical goal is to achieve a dose that is fully effective for your specific individual symptom profile.
It's a vital distinction that really shifts the power dynamic. It requires active participation from the patient. If you get to that 3-month review with your physician telling them, I feel a bit better, that isn't actually very helpful for optimizing your care.
Right, it's too vague.
Way too vague. Clinicians need specific data to make specific adjustments. Saying, my hot flashes dropped from 8 a day to 3 a day, but my sleep is still heavily disrupted between 2 a.m. and 4 a.m., that gives the clinician exactly the mechanics they need to adjust your protocol. Precise data allows for perfect dose optimization, so you have to track your symptoms meticulously from week 1 to week 12.
It's the difference between taking your car to the mechanic and saying, it's making a weird noise, versus saying, it squeaks specifically when I turn the steering wheel to the left at 40 miles an hour. The specific data point gets the problem solved so much faster.
Spot on. You are the only person who lives inside your body, so you have to act as its chief data collector during this transition.
Absolutely. So if you are listening to this and you are just starting your HRT journey or considering it, the overarching message from all these clinical sources is that this is a process measured in weeks and months, not hours and days.
Exactly.
You start with the adjustment phase while your receptors wake up. Then your internal thermostat resets and your sleep cycles return. Once you're finally sleeping, your mood stabilizes and the cognitive bandwidth returns. And slowly, in the background, those physical tissue repairs take hold. It is a biological sequence. You are literally building a new foundation.
This raises an important question, though. We've spent this entire deep dive analyzing the timeline of symptoms you can actively feel. The heat, the emotional shifts, the physical dryness. But what about the physiological changes you cannot feel?
The invisible benefits occurring behind the scenes.
Exactly. You might stop tracking your daily symptoms after month 3 because you finally feel like yourself again. But the most profound, life-altering changes from HRT are arguably the ones occurring completely beneath your awareness.
Like what?
Well, the clinical data reveals that starting HRT within 10 years of menopause yields a 20 to 37% reduction in your long-term bone fracture risk.
Wait, 20 to 37%. Let's dig into the mechanism there. How is the estrogen actually protecting the bones so drastically?
It basically comes down to cellular balance. Your bones are constantly being remodeled.
Ah.
You have cells called osteoblasts that build new bone, and cells called osteoclasts that break down old bone. Estrogen acts as a vital regulator for the osteoclasts. When estrogen plummets during menopause, the cells breaking down bone go into overdrive. They completely outpace the cells building it, which is what leads to osteoporosis.
Oh, wow, that's it.
Introducing HRT reins in those destructive cells, actively preserving your skeletal density. Furthermore, starting in that same 10-year window provides significant, documented long-term cardiovascular protection by helping to maintain the flexibility of your blood vessels.
Tying it all back to that freezing house we started with. Getting the heat turned back on so you are comfortable today is incredibly important. I mean, you absolutely deserve to be comfortable in your own house.
You do.
But what if the greatest benefit of your hormone therapy isn't what it does for your present comfort? What if the true miracle of HRT is the invisible architecture it is quietly reinforcing for your future longevity? Reining in those bone-depleting cells and keeping the walls of your house standing strong for decades to come.
That is the ultimate takeaway for anyone evaluating this treatment. It's not just about surviving the transition of menopause. It's about actively fortifying the body's structural integrity for the rest of your life.
What a profound way to look at it. A huge thank you to you, our listener, for joining us on this deep dive. Keep tracking your data, keep exploring your options, and most importantly, keep asking great questions about your own health. We'll see you next time.